You have to just face the computer like that. So we are not.
So role of muscles in facial pain. As we have all seen that not only facial pain, but there is a role of muscles in all types of pain. Be it just a myofascial pain, or be it a neuropathic pain, or be it a neuroplastic, nociceptive, chronic, centrally oriented pain. So there is always a role of muscles we have to address. Sorry? Okay. I am looking at them actually. So there is a role of muscles. So what is chronic facial orofacial pain? So chronic orofacial pain includes multiple pain conditions of musculoskeletal, neurovascular, nociplastic, and neuro. Can you just get that here? हाँ, मेरा bifocal का So it is characterized as pain in oral cavity, face, head, and sometimes neck for more than 15 days per month, lasting for more than 4 hours daily, and for at least 3 months. So basically, this is all getting covered. Can you get it down, or I can read from there?
इंटरनेट ना यहाँ पे राइट साइड पे नेट पे आ गया okay and you don't want this also ना this bar अब वो चला गया अपने आप अब कुछ
चलेगा, I'll read from here. It doesn't matter, I can read that. काय झालं जाते असू दे. So facial pain is a symptom which is situated at a cross point where multiple disciples meet. When patient gets facial pain, patient can either go to general practitioner as per, suppose they have a dental pain, patient can go to the dentist, ENT surgeon, neurologist, and by chance to the pain physician, or maybe referred from other faculties to the pain physician. And if nothing is happening, then he can be referred to the psychologist. So in 2020, there is a new international classification for orofacial pain was published, and all other societies like orofacial, head pain specialist, it is group of International Association of Study of Pain, American Society of Orofacial Pain, and International Headache Society. They all came together, and it is modeled on International Classification of Headache Disorders, ICHD. So I'm just going in brief because it is the two huge classification. Basically, they are divided into 7 subcategories. So first is the disorder due to dentoalveolar and anatomically related structures, dental pain, oral mucosa, salivary glands, jaw bone. Second is the myofascial orofacial pain, primary and secondary. Third is the temporomandibular joint pain. It is again primary and secondary. Fourth is the lesion or disease of the cranial nerve. So basically 2 main nerves which can cause neuralgia and facial pain, trigeminal nerve and the glossopharyngeal nerve. So trigeminal nerve neuralgia can be classified again into classical idiopathic, secondary, post-traumatic, and same with the glossopharyngeal neuralgia. What we see in pain clinic generally is a classical trigeminal nerve neuralgia, which is basically because of some vascular compression and the demyelination at the root level. Fifth category is presentation of primary headaches, orofacial migraine, tension type orofacial migraine, And then the trigeminal autonomic orofacial pain, like cluster type headaches, short lasting UV, conjunctival injection and tearing, and SULE, that is with autonomic symptoms. Fourth is a neurovascular orofacial pain. Sixth is idiopathic orofacial pain. Burning mouth syndrome, persistent idiopathic facial pain. That is what we used to call atypical facial pain. Persistent idiopathic dentoalveolar pain, constant unilateral facial pain with additional attack, and psychosocial assessment of patients with orofacial pain. Now it's very confusing, though this is all very well classified. When it comes to practicality or confirming the diagnosis, it is very challenging. It challenges the complacency and confidence of the physician whosoever is treating the patient. Because of its complex nature, because there are various nerve structures, joints, musculoskeletal parts involved, and overlapping and symptoms and overlapping location of pain. So there are also special organs in the facial area, 5 senses: ear, nose, eyes, tongue, and skin. The major masticating joint is temporomandibular joint. Then there are dental structures, and there is maximum sensory receptors present in these areas. So what is important is now history taking and clinical examination. I'm not going into details of investigation. Brief history taking is like characteristics of the pain, duration of the pain, what is the nature, intensity, frequency, is it associated with any other kind of pathology, is there aura or any trigger factors, any procedure like ablation or any surgery done, is patient on long-term medication, or is there any psychological or emotional agent. So it's my passion. We have to know first anatomy and physiology of the part which we are treating. So briefly going through the anatomy, sensory supply of facial structures are coming from 2 nerves, trigeminal nerve and the glossopharyngeal. Motor supply comes from facial nerve and some part of mandibular branch of trigeminal. Sympathetic supply is also very important in sympathetically mediated pain. We have to know this. So from where the sympathetic supply is coming, it is relayed from upper thoracic sympathetic chain via superior cervical ganglion along with various arterial supply of the face. Then again, there is a parasympathetic supply coming from 4 parasympathetic ganglions: ciliary ganglion, sphenopalatine, submandibular, and otic. So those which carry these parasympathetic fibers to the face are oculomotor, facial, and glossopharyngeal. So this is the basic anatomy. So yeah, see, I have a habit, whenever I have time, I go through YouTube videos again and again. One has to visit and do revision, revisit, because I keep on forgetting. So these are all facial, which you have learned yesterday. So 2 groups of muscles in the face. One is the muscles of facial expression, and one is masticatory muscles. So masticatory muscles come from the pharyngeal pouch 1, like embryological origin. Facial muscles of facial expression come from pharyngeal pouch 2. So motor supply to pharyngeal pouch 1 is trigeminal. Motor supply for facial expression is the facial. So this is the brief I have given: intracranial part of the facial nerve and the extracranial part. There is a one motor nucleus, one sensory. It goes to the internal, I'll show you. It goes to the internal auditory meatus. Then it comes to the facial canal. It दिसत नाही ना? So when it comes out of the internal auditory meatus, it forms the facial, it goes through the facial canal. There is a geniculate ganglion which is situated over there. From there, the 2 nerves come. One is the greater petrosal nerve. It carries the secretomotor, that is the parasympathetic fibers, and goes along with the deeper petrosal nerve in the pterygopalatine canal to the pterygopalatine fossa. Then there is a nerve to the stapedius. When it comes out of cranial portion, it comes out through the stylomastoid foramen, and it gives the motor branches. Posterior branches will be the posterior auricular nerve, now to the digastric, now to the stylohyoid. And then it passes under the parotid gland and then gives a, these are the extra cranial muscles, temporal branches, zygomatic, buccal, marginal mandibular, and cervical branch. So this is the brief of facial nerve. Primarily, it is a motor nerve except sensory innervation to small part of ear. The trigeminal nerve supply is again divided by V1, V2, and V3 branches. That is the ophthalmic, maxillary, and mandibular. So this is the basic diagram of the trigeminal nerve. Trigeminal nerve.
In the neck, below the neck, it is the glossy group.
There are three sensory nucleus of trigeminal nerve and one motor nucleus. It's difficult for me to point out here, but this is the motor and this is the chief sensory nerve. Chief sensory nucleus, one is a mesencephalic, which is present in the midbrain, chief sensory in the pons, and this is the spinal nucleus, which is very important. It is the longest nucleus, which spreads from the medulla to the upper spinal level till the C1, C2 level. Okay, 3:1 is a good proportion for trigeminal to remember and mandibular branch specifically because 3 nucleus, 1 motor. When it comes out to the mandibular nerve, when it comes out to the foramina oval, it gives out 3 motor and 1 sensory branch. Okay, this is the actual main trunk of the trigeminal. The 3 branches goes to the medial pterygoid, tensor palatine, and tensor tympani. The sensory branch is the meningeal branch, which again goes back to the intracranial through foramen of spinal. The branch descends and forms a 2 divisions, anterior division and a posterior division. Again, there is a 3:1 proportion, 3 motor, 1 sensory. Posterior division has 3 sensory and 1 motor. Red is the motor and green is the sensory. So anterior branches, 3 motor divisions will be to all masticatory muscles, temporalis, lateral pterygoid, and the masseter. And the sensory branch will come for the buccal nerve. The posterior division has 3 sensory: auriculotemporal, lingual nerve, and the inferior alveolar nerve. So auriculotemporal gives the sensory innervation to the temporomandibular joint. It also gives to the temporal part of the face, and it also gives sensory innervation to the parotid gland. The buccal nerve, the lingual nerve, which is also very important because it carries sensation from the anterior part of the tongue. The chorda tympani, which comes from the facial, it will meet the lingual nerve, and it carries the parasympathetic secretomotor fibers, which will be passed to the submandibular ganglia, and the parasympathetic supply to submandibular gland and the sublingual gland. Okay. I cannot move my hand. Huh? You have got? But it is moving. So 3 sensors. Right? Motor and 1 sensor. Okay. Motor will go to the pterygoid. So medial pterygoid, that is the main branch. Comes down. Now, temporal, all the tip of the other one, the buckle. Madam, it comes from maxillary, superior and middle and end.
So those, this is the reason why. Because the sense it is
Post-traumatic neuropathy, trigeminal neuropathy.
that is very important. Thanks.
Okay.
Was unnecessary. Both are possible.
The motor now from the posterior branch, which supplies to the mylohyoid muscle and the anterior belly of the digastric. Okay. Now coming to the mandibular branch, same thing actually. Coming to the maxillary now, it arises from anterior aspect of trigeminal ganglion. It passes along the lateral wall of cavernous sinus, leaves cranial cavity through foramen of rotundum, enters the pterygopalatine canal. Okay, in the pterygopalatine canal, it gives two branches to the pterygopalatine ganglion, which actually also get the nerve from the median nerve, that is the greater petrosal and the deep petrosal. Greater petrosal is parasympathetic, deep petrosal is a sympathetic. Okay. Then it enters the orbit via inferior orbital fissure. It runs through the infraorbital groove and canal in the floor of the orbit, and it reaches the face via infraorbital foramen. So this is the diagrammatic this thing. So before the foramen of rotundum, now it gives the meningeal branch. So all the three branches of trigeminal gives innervation to the meninges.
You can see meninges are highly sensitive. So maximum irritation can cause
Mandibular
of the
okay. Now this is the infraorbital fissure. Before that, it will give a branch that is the posterior superior alveolar. This is the middle superior. This is middle superior alveolar, and this is the anterior superior alveolar branches, which will innervate the upper set of teeth, gingiva, and basically oral structures. One branch will be going to the zygomaticotemporal and zygomaticofacial. So now here you can see the pterygopalatine fossa, from where the parasympathetic fibers are coming. It will go via zygomaticotemporal, and it will jump to the ophthalmic branch to the lacrimal nerve and supplies the lacrimal gland. Got it. I hope so that parasympathetic fiber is jumping from one nerve to another nerve, and it's reaching the lacrimal gland. When it comes out of the intraorbital foramina, again the three branches: palpebral branch, nasal branch, and the labial branch. Coming to the front, basically the ophthalmic nerve, 3 branches: frontal nerve, lacrimal nerve, and the nasociliary nerve. Okay, so here you can see to the lacrimal gland from the zygomatic-temporal, the parasympathetic fibers will join and secretomotor fibers will be supplied to the lacrimal gland. From the frontal nerve, when it comes out from the superior orbital fissure, it forms the 2 branches, supratrochlear and supraorbital, and they will supply the frontalis muscle and front part of the face. From nasociliary nerve, there is a ciliary ganglion from where the parasympathetic fibers of oculomotor nerve is coming. These are also supplying to the sphincter, papillae, and ciliary muscles. Okay, the long ciliary nerve carries the sympathetic fibers and it supplies to the vascular plexus around the orbit, and it supplies to the dilator sphincter. The motor branches will go to posterior ethmoidal, anterior ethmoidal, and the infratrochlear nerve. So this is the structure of the ophthalmic nerve. See, this is the trigeminal nuclei, which I was saying, the big spinal nuclei. Why it is important? Because there is a convergence of trigeminal afferents and the upper cervical nerve afferents, which converge at a second order neuron over here. So there is always a cross referral pain. If it is arising from the trigeminal area, your cervical area might also, muscle might also becomes, they can produce the trigger points and the pain basically, and vice versa. So up to C2, maximum up to C3, there is a convergence of trigeminal afferent and upper cervical. I have a overlapped. There are actually many overlapping at every level. Even they say ophthalmic branch when it is crossing over the optic nerve. So whenever there is a herpes zoster of ophthalmic branch, they say that it can cross over to the optic nerve and patient can get the blindness.
And the oculomotor nerve which moves
so that is why
like muscles.
proprioception and everything is very.
Everything is connected in there.
So again, revision of sympathetic, parasympathetic. Sympathetic comes from the relay from the upper thoracic sympathetics and superior cervical ganglion, which basically go along with the internal carotid nerve, external carotid nerve plexus, and innervation of blood vessels. It supplies to the dilator pupillae. Parasympathetics, there are 4 ganglions: ciliary, sphenopalatine, otic, and submandibular. Ciliary ganglion, it basically lies in the ophthalmic branch, but carries sympathetic fibers from oculomotor to ciliary pupillae, ciliary ganglion, sphincter pupillae, and ciliary muscles. Sphenopalatine ganglion is via maxillary branch, but parasympathetics come from facial, greater superficial petrosal nerve, which supplies to the lacrimal gland, nasal mucosa, and the sinus wall. Otic ganglion, mandibular branch, parasympathetics come from the glossopharyngeal nerve. Submandibular ganglion, again lingual, coming from chorda tympani, parasympathetic fibers, and submandibular and sublingual. So where do the patient feel the pain when there is a trigeminal neuralgia? Depending upon the division B1, B2, and B3. It is generally unilateral. Episodes of severe shooting, lancinating, electric shock-like paroxysmal pain last for few seconds to minutes, can spread to wider area later. There are trigger points like brushing, eating, wind blow, hot or cold touch, or even speaking, generally due to demyelination of the nerve at the root level. So this is by Jovin, they have shown that patient can get referral pattern of pain from the myofascial structures: sternocleidomastoid and upper trapezius, temporalis anterior and posterior, deep posterior masseter, the lateral pterygoids and the medial pterygoids. So you can see the overlap of the referral pattern of the pain. This is coming from the referred pain is coming from the noxious stimulation of basal occipital periosteum and interspinous, like the cervical basically muscles, suboccipital muscles, or maybe from splenius capitis, even sternocleidomastoid. So the classical is from occipital to C1 and from C1 to C2. You will see major representation of pain over the frontal part, periorbital, temporalis, and zygomatic area. But as you go down, you will see less and less referred pain over the face. So, because in the nucleus is up to C1, C2, maximum C3. This is the pain coming from the facet joint. So C1, C2 and C2, C3 has maximal presentation over the face in the referral pattern. These are the masticating muscles. Temporalis, masseter, lateral pterygoid and the medial pterygoid. Each has two heads, deep and superficial, medial and lateral vertebra. So where do they feel, if there is a TM joint involvement, where do the patient feel pain? It is generally the periorbital area, eyebrow, teeth, sinus, preauricular area, temporal area, and even at the base of the skull. So what are the symptoms when you get the TM joint pain? So patient can get headaches, dizziness, they can get tinnitus, little of deafness, earaches, jaw, there might be locked jaw, difficulty in chewing, decreased range of motion, pain when chewing, general jaw pain, swelling. There may be discomfort in the or stiffness in the neck. There will be clicking sound, grating sound. So all these are the symptoms of TM joint pain. Again, you can see the referral pattern of myofascial in the pain when you get TM joint pain, and difficult to differentiate clinically that it is coming from the muscles or is it coming from the joint. But all other symptoms can indicate it's coming from the joint. There is an association between TM joint pain and the neck pain. These are the papers where they have mentioned that they have found a strong correlation between upper cervical neck movements and masseter muscle activity. There is an asymmetrical compensation mechanism between the sternocleidomastoid and masseter and temporalis jaw muscles. Poor posture is very important. Poor posture related to computer use can also result into the jaw muscle pain, neck pain, and even the shoulder pain. So it is all interrelated. Even the posture, even the discrepancy in the leg, it seems they have mentioned in one paper, can lead to the TM joint disorder. Relationship between the jaw opening and closing with head and neck motion. There is a functional linkage between the temporomandibular region and neck region involving TM joint, upper cervical, craniocervical, and joints of the cervical spine. So one has to, when there is a TM joint pain, one has to look for other causalities also. Now, which are the muscles for jaw movements and what do they do? Elevation and closing of the jaw, temporalis, masseter, and medial pterygoid. Depression will be first, lateral pterygoid will be in action. It will protrude the jaw. Why protrude the jaw? Because to prevent the impingement of angle of jaw over the parotid and sternocleidomastoid. And digastrics and geniohyoid and mylohyoid will depress the jaw. The protrusion, again, both the pterygoids, mandible retraction, temporalis fibers, side to side movement, again the pterygoids. So what are the common facial pain conditions which generally are seen in the clinics? It is a trigeminal neuralgia that is also classical, which is only mainly seen in the pain clinics. Trigeminal autonomic neuralgia, that is a cluster headaches and some temporomandibular disorders. Post-herpetic neuralgia involving trigeminal nerve branch B1, B2. Maybe the Ramsay-Hunt syndrome, it is the herpes of the oticus facial nerve involvement. Then one can also see the post-Bell's palsy facial pain, persistent idiopathic facial pain, that is the atypical facial pain, idiopathic odontalgia, post-traumatic. That's what Madam was mentioning. Post-dental extraction, when the patient feels the pain, that is a post-traumatic trigeminal neuralgia, cancer pain. But I am not going to go into details. And post-surgical or post-procedural pain, like the deafferentation pain post-radiofrequency or any tooth extraction.
Whatever. Look at this whole slide.
Or better. Madam, I will tell you, I had such patient. He got somewhat relief with the neck. No relief.
No, I can make it now. But I cannot.
So this is again the trigeminal neuralgia patient. You can see the restricted mouth opening before and after first session of dry needling. There is a mouth opening. It is in the mouth opening. Again, same, she is a patient of trigeminal neuralgia, but it is not classical. She was on medication, but it was again flaring up of the symptoms and dry needling was done for her. So after first session, she said she had 50 to 60% pain relief. The intensity is less. And after second session, she said that she got a good amount of pain relief. But they don't come for further session.
Because they feel
These are neck muscles which are addressed for the facial pain, paraspinal muscles. This is an interesting lady. This is basically, she has a temporal, only on temporal area, there is a pain for last 5 to 6 years. And it has happened only by minor, she says minor blow over the head. We don't know. But there was allodynia, there was hypersensitivity, and she was not even allowing us to touch. Only one dry needling. I said, let me try with dry needling. And then she wanted us to do more invasive procedures or more investigation like USG and CT scan. Because she has been referred to everybody, physician, surgeon, orthopedician, and neurologist. And then she has come to us. So everything was done to rule out other causes. But first dry needling, again, she said same thing, 50 to 60% pain relief and intensity is less. And we
had a similar patient.
This is concern. So let's see, she will be under follow. This is the again CA cheek patient operated. The CA has come to the other part of the face. He's put on medication, but dry needling is being done, but it's a private patient, so they don't come so often and so regularly. This is a herpes involving the ophthalmic and maxillary. One is the selfie and the other one is, so that's why you can see the different opposite sides. So ophthalmic and maxillary now. This is the COVID time. You can see the actually hanky around the face, which is the mask. So patient is put on medication. Also, patient was given lignocave patches because patient was not able to come to the clinic, and antiviral and neuropathic pain medication. Flare up. So known patient. So they didn't know what is the pain, why it is burning, severe lacrimation, nasal, discharge, active. So he got actually antivirus within first 2 hours of. You can see the lot of eyelid, edema, conjunctival involvement.
Is there any
Active virus nare. Virus. See, generally they have been put on medication, antivirals and neuropathic pain medicine and anti-inflammatory.
But if you do need suddenly the rashes,
I gave him lignocaine patch.
that is a good.
Initially,
If you wish to do need, let's say, cannot go everywhere. The maximum come from here, or you can come from here. Around the lesions. Around. Some really curious about it, but I don't know.
patient coming to us in this stage of herpes is very, very uncommon. We come generally for post-herpes neuralgia, but this is the case of active.
No, actually also many people do come, but not very.
Unless I'm not as a general patient.
And the disease is active. You hardly it is
because action depends. But patient said he did second now. He did like the and conjunctival
something like I am myself. At this doing for sure. So I manage somehow for the 3 days. So I told her,
I think there is also involvement of erythropoiesis. So that is why there is.
That is why this.
It's a proper inflammation. Everything. It's active.
So if you.
There is a sympathetic involvement.
Or make steady so that you can with the rashes and subside.
But I'll tell it, patient doesn't want any intervention at that particular moment. Very painful. And the eyes are like watering eyes, nasal, and that age they are vulnerable. Yes, very bad. And lignocaine patches help a lot for herpes. not my patient, but I took it from the internet. This is a dry needling in the post-Bell palsy pain patients. So now these are the few references which I have collected. It's the ultrasound guided dry needling of Madam's of masticatory muscles in trigeminal neuralgia, published in 2022. So the trigeminal neuralgia may be neuromyalgia, and that can be addressed specifically by ultrasound guided dry needling and customized physiotherapy with yoga mudra, along with judicious use of other procedures. The second paper is from India only. So I took it because I found it very interesting. So there is a case report, alternative treatment for trigeminal neuralgia in a young patient. It's a management of a young patient with trigeminal neuralgia refractory to medical management could be challenging. In such scenario, dry needling could offer a relative safe and effective treatment in comparison to RFR.
Now, Gautam Das is a convert into myofascial.
Only thing is, I didn't put the picture. The needling which they have done is the intramuscular needles. Anyway. Maybe कुछ दिया होगा लोग. Also case report by Dr. Mary mentioning the dry needling as part of treatment for Meniere's disease. Like, what is this? This is the history of tinnitus, unilateral deafness, oral fullness, vertigo, restricted neck movements, sleep disturbances, refractory to oral medication. I think she had given trigger injections followed by dry needling over masseter, sternocleidomastoids, splenius capitis, spinalis, trapezius, in first session, 60% relief from tinnitus and deafness and gradual reduction from neck and shoulder stiffness. With the intramuscular injection and dry needling within masticatory muscles in management of myofascial pain. There is a systematic review and clinical trials.
Is it Davis?
So in temporomandibular disorders, myofascial pain in masticatory muscle is a major component. Needling within these masticatory muscles provides satisfactory effects while being simple, safe, and accessible procedure, although there is a still need for high quality clinical trials. And the needling within lateral and medial pterygoid helps a lot. And especially when you don't want to go for Botox. There is a deep dry needling of trigger points located in lateral pterygoid muscle. Efficacy and safety of treatment of management of myofascial pain and temporomandibular dysfunction. Another paper. The deep dry needling in lateral pterygoid muscle showed better efficacy and safety in reducing pain and improving maximum mouth opening, laterality, protrusion movements in patients with chronic myofascial pain located in that muscle, compared with an oral whatever treatment. And there is this improvement persisted for 8 weeks. That's what they had mentioned. Then ultrasound guided dry needling for trigger point inactivation in the treatment of post herpes neuralgia. What you are saying, mixed with myofascial pain syndrome, a prospective and control study. It concludes that ultrasound guided dry needling can be safely applied to post-herpes neuralgia patients mixed with myofascial syndrome. Dry needling and intradermal needling, press needling were more effective than only pharmacotherapeutic treatment for PHN mixed with MPS, with low recurrent rate and high patient satisfaction rate. Another paper is on post-facial palsy, Bell's palsy, the use of myofascial technique, that is a dry needling for treatment of maintained muscle contraction in peripheral facial palsy sequelae. So what happens in post-paralytic pain syndrome? It is defined as a conglomerate of clinical manifestation secondary to aberrant reinnervation of facial nerve and which includes the synkinetic muscle movements, maintained muscle contraction of certain muscles, spasms, myokymia, aberrant regeneration of nerve can cause muscle contraction and trigger points. So all this is there is a significant improvement in both pain and movement when there is a Welch palsy. Two cases which I want to mention, I don't have pictures. See, one patient had a atypical facial pain. Patient was post CABG just 5-6 months after, and he said this pain is before like 4-5 years. I'm having atypical, and his pain was bilateral and very vague pain. So when I examined, there were trigger points over the masticatory muscles. There were trigger points over the severe trigger points over the cervical and sternocleidomastoid. First session was done on the back because he was little skeptical about the facial component, along with the ultrasound and TENS therapy. So he said that there is a reduction in the facial pain. And then he was, all these muscles were addressed, and he was put on gabapentin. So this is the case. Another case is patient had severe allodynia on one aspect, frontalis, and patient was like not allowing us even to touch. So it was difficult even to give local over the, and we didn't have RF machine or anything else. So we just wanted to do test dose about frontal nerve and supratrochlear nerve. So patient got a good relief. In that session only, once the both the nerves were blocked, we did dry needling over the frontalis and basically this part of the face. Patient had 80 to 90% of pain relief. And again, 2-3 sessions we did for dry needling. And this was also for lingering for many, many years. Even if you give, basically quieten the nerve and then address the muscles.